This is Justine Spargo recording the expectant family needs and care. This is for Learning Plan 7, and this is for Chapter 10. Again, Chapter 9 we will review in class. Let's move on to our objectives for this PowerPoint slide. So first, we want to describe the significance of using the nursing process to promote health in the woman and her family during pregnancy. We want to describe actions the nurse can take to help maintain the well-being of the expectant father and siblings during a family's pregnancy. Identify information that expectant parents may need to assist them in making the best decisions possible about issues related to pregnancy, labor, and birth. Explain the basic goals of childbirth education and providing care to expectant couples and their families. Identify the common discomforts of pregnancy and their causes. Then we want to describe the recommended levels of weight gain during pregnancy when providing nursing care for pregnant women. Explain the significance of specific nutrients in the diet of a pregnant woman. Compare nutritional needs during pregnancy, the postpartum period, and lactation with non-pregnant requirements. Compare recommendations for weight gain and nutrient intake in the pregnant adolescent with those for the mature pregnant adult. Describe basic factors a nurse should consider when offering nutritional counseling to a pregnant adolescent. And then compare nutritional counseling issues for breastfeeding and formula feeding mothers. All right, so childbearing decisions. Birth plan. Birth plan identifies aspects of the childbearing experience that are most important to the parents. It sets priorities for the birth experience. So they can take their birth plan with them to their visits, to their provider, to the hospital, or wherever they plan to deliver. And all of the expectations should be discussed before labor, not, oh, I'm in labor now, I need to discuss what I want to happen or what I envision. Okay, because every woman will envision how her labor will go. So at least if she has some sort of plan, she feels like she has more control. So make sure to discuss possible obstetric interventions as part of that birth plan, or even make two birth plans for what happens. So if someone had their heart set on a home delivery with the midwife and then there needs to be a transportation to the hospital, make sure to address the patient and let them know as their nurse that you know that this isn't their birth plan, it's not expected, but you're here to help make the best possible birth experience for them. So we work with midwives in transition of care and listen to everything that they have to say. And they have specialized training to do births at home. So think of them as an extension of your birthing unit at the hospital when when you're there and they come in with a patient or a patient comes in from home. Okay. And finally, nurses need to help expectant parents keep sight of what's actually realistic for their situation. So having a natural delivery when baby is breech probably isn't realistic, but make sure that you've covered everything from the care provider to, again, their birth preference plan, the birth setting. So maybe again at home versus the hospital or someplace else. Do they have labor support? A doula? Who is their support? Is it their mom? Is it their husband? Is it a best friend? And then sometimes there's even sibling participation in the birth. So depending on the age and things like that, siblings could participate to a certain extent in the birth, or even making sure that there's someone around to watch the child, or what's the plan for if you go on delivery, where are the other kids going to go, or who's going to watch the other kids. But if there is a sibling participation, there needs to be a designated adult that is assigned to that sibling, because our job as nurses are to care for our patient, and our patient is mom, and then it'll be babe as well. Okay. All right. So classes for family members during pregnancy. Um, so there's early classes during the first trimester. A lot of times they go through early gestational changes. They discuss self-care during pregnancy, fetal development, environmental dangers for the fetus, sexuality in pregnancy, birth settings and types of care providers that are out there, nutrition, rest, and exercise suggestions, relief measures for common discomforts of pregnancy, uh, psychological changes in pregnancy, are information for getting pregnancy off to a good start. So best practice shows to do teaching in a chronology in chronological order with a pregnancy. So we don't talk about labor and delivery until we talk about the first trimester, second trimester, and finally the third trimester. So do them in order. That and it makes more sense to people. Then later on, uh, there's classes that go through that second and third trimester that usually discuss preparation for birth process, postpartum self-care, birth choices, relaxation techniques, breathing techniques, infant stimulation and infant massage, and then newborn safety issues. All right, education for family having a cesarean birth. So about 32.8% of births are cesarean. There are new childbirth preparation classes that they do offer out there instead of just vaginal delivery ones. Classes should cover what the parent can expect to happen during that cesarean birth and what they might feel and what choices are available to them. We want to encourage them to identify what they would like to change and to list the interventions that would make the experience more positive for them. Um, the mother usually needs reassurance that subsequent cesarean births are often less painful than the first. So the first one's usually the most frightening because it's the first go around. But then after that, since they've cut through some nerve endings, it's usually less painful for them. The positive is that planned birth involves less fatigue because they're not preceded by a long, strenuous labor. And you get to pick the date of the delivery usually, unless you go into labor early. And then you can ensure that your family are there for the delivery. So it's not, oh, I wonder when baby comes. I hope it doesn't come during this time or that time. Um, and you know that there is a set end date in mind that you're not going to go 2 weeks overdue. So it is nice that way. But it's also nice to have um, some choices, where do you want dad to be? Do you want dad to be here? Do you want baby to skin right away? Would you like to try breastfeeding right away? So there's still some of those same options that are available. And so uh, they're just choices, and moms do need choices to feel like they have some control. So preparation for parents desiring a trial of labor after cesarean birth. It's also called TOLAC. So it was previously termed vaginal birth after cesarean birth. So VBAC was the term that they used, but now it's TOLAC. So most parents will have unresolved questions and concerns about their last birth, if it was a C-section, whether it was emergent, or could they have delivered vaginally. There's always lots and lots of questions. And the nurse can supply information about the criteria necessary to attempt that trial of labor and identify some decisions to be made regarding the birth experience. So again, they should have probably two birth plans in place. So if they're going to try the TOLAC, make sure that they have another birth plan in place for if they need to have another cesarean. The risk of actually having another cesarean is higher. A lot of our small local hospitals do not do them because there is a greater risk of the placenta of the uterus actually rupturing because um, once you've cut through the abdominal wall and you've cut through that uterus once the body starts having contractions, it'll actually put stress on that uterus, and it's like having a balloon that's been overstretched, and then you barely tap it, and then it'll pop. So the same concept kind of occurs where it has a lot of tension. It's been cut once, so now there's more of a chance of it actually popping open on its own because that wall has been weakened from being cut into before. Okay. So some considerations again to consider is uh, if they're going to do the TOLAC, they need to have immediate access to emergency surgery. They need to have had a previous C-section with low transverse incision. They need to have an adequate pelvis. So if your pelvis is too small and baby's too big, there's no way that baby's going to fit through, that little hole. It's not happening. Um, you need to await spontaneous labor, so you don't get a set date. You have to wait until you go into labor on your own. And you need to show progression. So if you're laboring for hours on end, they're not going to continue and sit there and wait. They're going to want to take that baby and do C-section just for the safety of you and for babe or for mom and babe. All right, so maternal nutrition. This is chapter 11. Fetal growth occurs in 3 overlapping stages. So we have growth by increase in cell number, growth by increase in cell number and cell size, and then growth by cell size alone. So nutritional problems that interfere with cell division may have permanent consequences. So if nutritional deficits occur when the cells are mainly enlarging, so that's usually early on, changes usually are reversible when normal nutrition resumes. Maternal weight gain. So let's talk about BMI. So BMI is the measure of body fat based on height and weight, which I'm sure we've all done that before, looked at or been told what our BMI is. And an adequate weight gain indicates an adequate caloric intake, but does not ensure that a woman has a good diet. Okay, so just because someone is gaining weight doesn't mean that they're eating well. So maybe they're eating McDonald's every day and all the junk food and they're gaining weight and not eating healthy. Okay, so an underweight woman, so that's a BMI less than 18.5, needs to gain about 28 to 40 pounds during the pregnancy to have adequate nutrition for babe. A normal weight woman with BMI between 18.5 to 24.9 needs to gain about 25 to 35 pounds. An overweight woman with a BMI between 25 to 29.9 needs to gain about 15 to 25 pounds. And an obese woman with her BMI equal to or greater than 30 needs to gain only about 11 to 20 pounds, if not any weight at all. All right, so let's talk about the distribution of weight gain in a pregnant woman. So, on average, about 11 pounds is from the fetus, the placenta, and the amniotic fluid. The uterus weighs about 2 pounds. The actual increase in blood volume is accounts for about 4 pounds total in the body. And then the breast tissue enlarges and adds extra fluid as well. That's about 3 pounds. And then you have an extra 5 to 10 pounds in maternal stores. So we're looking at about 25 to 30 pounds. And we just talked about how a normal woman should gain about that. But that's a lot of extra weight just um, with all the stuff. I mean, even without the fetus, the placenta, and the amniotic fluid, that's quite a bit of weight gain. That's that's a lot. So, all right, prenatal high risk. So, weight greater than 200 pounds. Okay, so that's if they're greater than 200 pounds, then they're at a greater risk for gestational diabetes, preeclampsia, an induction of labor, a cesarean birth, anesthesia complications, venous thrombosis, postpartum hemorrhage, fetal anomalies, macrosomia, which is a baby more than 8 pounds, 13 ounces, birth injury for baby trying to get out, uh, stillbirth, and then complications for children, which would be like predisposed to developing obesity and related health concerns after they're born. Now, for a woman that weighs less than 100 pounds, they're at an increased risk for hypertension, birth injury, cephalopelvic disproportion, prolonged labor, intrauterine growth restriction are small for gestational age, the baby's real small, and then hypoxia of the infant. So none of those are good. Let's talk about nutritional requirements. So carbohydrates, which is our primary energy source, um, it gives us weight gain and growth of the fetus and placenta, so that's all good. Protein is good for amino acids for growth of a tissue. A fat is good for maternal energy and it promotes fetal fat deposits to help keep the baby warm and cushy. Calcium and phosphorus and mineralization of fetal bone and teeth is what that's good for. Iodine is good for the fetal thyroid gland function. Sodium helps regulate that fluid balance and metabolism in mom. Zinc is good for growth of the fetus and sufficient lactation. Magnesium is for cellular metabolism and bone mineralization. Iron is for maternal anemia and contributes to fetal and infant stores of iron because baby can't make its own at that point. And vitamins, so fat and water soluble, maintain good maternal health and then folic acid prior to pregnancy. So they may prevent neural tube defects in a fetus if they need folic acid. So a lot of these are in the prenatal vitamins, but carbohydrates clearly are not, proteins are not, fats are not. Those are all consumed by, are taken in from what mom eats or drinks. Nutritional needs during pregnancy, postpartum, and lactation compared with non-pregnant women. So eating for two is a common misconception and can lead to overeating. So don't ever say, well, you're eating for two, you can eat more. Well, no, not really. You don't need to eat for two at all. You don't need any extra caloric intake until later in your pregnancy. No changes in eating again for that first trimester. It's not until that second and third trimester where you have an increase of 300 kilocalories per day. And then during lactation, you need another 200 kilocalories per day. Protein will increase by 14 grams to 60 grams per day when someone's lactating or pregnant. Calcium's 1,000 to 1,300 milligrams per day, depending on if they're 19 years old or younger or older. Magnesium is 350 milligrams per day. And then the iron actually increases to 27 milligrams per day. And a lot of times that's in your prenatal supplements, like we mentioned before, for the neural tube defects. Fluid requirements. So water is essential for life and all body tissues. It serves as a lubricant, a medium for transportation for carrying substances in and out of the body, and affects blood pressure and aids in temperature control. So it's really important for the body to make sure that you have enough fluid. So we encourage moms to consume at least 8 to 10 8-ounce glasses of fluid each day, and 4 to 6 of those should be water. So it shouldn't be all pop or all juice. Majority of them should be water. Soda and diet soda, they can have in moderation. And then caffeinated beverages actually have a diuretic effect. So it makes mom actually void more, which then dehydrates them. So we actually encourage them to avoid any caffeinated beverages. It's not good for mom. All right, factors influencing nutrition. So some common discomforts of pregnancy um, can be like GI functioning, like nausea, vomiting, heartburn, and constipation. So we may be taking um, some different supplements or doing some things to help maybe so that way we can eat more so we're not so nauseated and things. Use of artificial sweeteners. They're acceptable for use during pregnancy in moderation. Herbs or cams. Make sure that you tell mom to take cautiously for the safety of supplements and herbs and consult a reputable source or their provider because not all herbs or cams are safe for mom and babe. Energy drinks. They can cause a variety of symptoms such as anxiety, headache, agitation, tremors, seizures, psychosis, altered mental state. So make sure, again, you tell them to use cautiously. Foodborne illnesses. Moms are at risk for an increased risk for salmonella contamination in raw eggs, listeria, monocytogenes, and unpasteurized milk and dairy products, meat, poultry, and seafood. To make sure things are refrigerated or freeze within 2 hours. Don't encourage them to eat hot dogs or luncheon meat. Avoid soft cheeses. Avoid refrigerated smoked seafood. But canned or shelf stale are considered safe. So really need to watch what they're eating so that way they don't become severely ill. Now, mercury in fish, that's a serious threat developing to the developing nervous system of an unborn baby or a young child. Canned light tuna, shrimp, salmon, catfish, and pollock are lower in mercury. Albacore tuna has more mercury than canned light tuna, so only eat about 6 ounces per week if they really like that. A lactose deficiency, so inadequate amounts of the enzyme lactase, which breaks down the milk sugar lactose into smaller digestible substances. So if someone's lactose intolerant. So the enzyme is available over the counter in tablets or drops. You can ingest lactase treated milk. Cultural, ethnic, and religious influences can play a part in their nutrition. So certain foods have different symbolic meanings. So they need to eat cold foods or hot foods when they don't feel good, things like that. Psychosocial factors, food choices can be a symbol of friendliness, warmth, and social acceptance. So just for company or only on special occasions. Socioeconomic levels may be determined of nutritional status. So if you have certain foods, you're considered um, like being rich if you're able to have certain foods. Eating disorders, so anorexia nervosa and bulimia. So women with anorexia don't often become pregnant because of the physiologic changes that affect their reproductive system. So they actually have a hard time getting pregnant or staying pregnant. But women with bulimia can become pregnant and then have the same symptoms as hyperemesis gravidarum. So make sure that you closely monitor and support them throughout their pregnancy. So that way they maintain or gain weight and get healthy foods in and healthful nutrition. All right, so pica or pica um, is basically persistent eating of substances that are not ordinarily considered edible or have any nutritional value. So, like soil, clay, powdered laundry starch, cornstarch, soap, baking powder, ice, freezer or frost burn matches, paint or ashes are common things that people eat. Complications could basically fill the intestines and cause fecal impaction. Eating starch may be associated with excessive weight gain. Lead levels could become dangerous. So we need to have a non-judgmental approach as nurses, but we need to help them switch to eating non-fat, like powdered milk instead of uh, the starch. Maybe frozen fruit instead of like the freezer or frost burnt stuff or ice. Um, Sucking on hard lemons or mint candies may help deter some of the other things that they may crave. And it only happens during pregnancy. Okay, so it doesn't happen all the time, but it only happens during pregnancy and can result in iron deficiency anemia because you're not getting the right nutrients that you need. Nutrition care for the pregnant adolescent. So young adolescents are more likely to still be growing, which can affect the fetus development because you have a mom that's growing still and now she's trying to grow a fetus herself. Most adolescent eating patterns are pretty irregular and change from day to day, depending on, oh, what are we having today? I forgot to bring lunch. It's kind of spur of the moment when they do eat, and so they don't always make the best decisions. So we need to encourage them to take healthful snacks with them or plan out the times that they will eat. So nutrition related factors to assess would be low pre-pregnant weight, low weight gain in the pregnancy, a young age at menarche, if they smoke, if they have any chronic diseases, they have a history of eating disorders, excessive pre-pregnant weight, anemia, or unhealthful lifestyle. And young adolescents need to actually gain more weight than older adolescents because again they're growing themselves, so they need extra nutrients for themselves to grow besides extra nutrients for that baby. And then nutrients need more iron, calcium, and folic acid than adolescents do. And then finally, nutritional requirements for breastfeeding mother. So caloric requirements, so again, increase by 200 kilocal per day over your pregnancy needs. So inadequate caloric intake can reduce milk volume, but the reduced milk volume has no effect on the milk quality. So it's still good quality, it just isn't as much. So calories, you need about 2,500, 2,700 kilocalories per day, or 200 kilocalories over your pregnancy, or 500 kilocalories over a pre-pregnant requirement. Protein, you need about 65 grams per day during the first trimester or the first 6 months, and then 62 during the second or 6 months of the second half of the pregnancy. Calcium, you need about 1,000 milligrams per day. And then we always tell them to avoid foods that cause distress to infants because sometimes babies will kind of seem like they're colicky or they get upset stomachs. I know for myself, my son, I couldn't have anything garlic because every time I ate garlic, then he became more crabby and had more like acted like he was uncomfortable and more gassy when I had garlic. So I couldn't eat a whole lot of pasta with him. And then we always encourage them to drink at least 8 to 10 8-ounce glasses of fluid daily because if they're making milk and they're making extra fluid and they're getting rid of it, they need to be able to replace that. And then usually if they are drinking more fluids, that'll help with their milk supply, produce more milk if they're well hydrated. So that's the end of this PowerPoint slide.